Ok, possiamo iniziare, ci sediamo. We will start in a few minutes, Barbara. Okay, let's begin. Welcome to this second session. I'm Linda Lombi from Catholic University of Milan, and I will be chairing this second session of our conference that is dedicated to the topic of personalized medicine. I'm not sure that everyone is familiar with personalized medicine, so I wanted to very briefly introduce the topic of this session. And when we talk about personalized medicine, we are talking about an emerging approach in disease treatment and prevention that adopt a very tailored approach to prevention and treatment. The promise of personalized medicine is to treat, prevent, and predict disease in a very tailored way. And today we will have two speakers that will face this topic from two different perspectives. And I will briefly introduce them, starting from Barbara, that I'm honored to introduce. Hello, Barbara. Can you hear me? Okay. So Barbara is a professor and the head of the Department of Political Science at the University of Vienna, where she also directed the Center for Study of Contemporary Solidarity and the Interdisciplinary Research Platform. She wrote many books about personalized medicine, and I want to mention particularly two books. The first is Personalized Medicine, Empowered Patient in the 21st Century. And more recently, she published another book, The Pandemic Within, Policy Making for a Better World. So I wanted to welcome Barbara. I had the chance to talk with Barbara before this conference, and I'm sure that her speech will raise many questions. So Barbara, you have 30 minutes, and after that 10 or 15 minutes for the debate. The screen is yours, Barbara.
Thank you very much, Linda, and thank you everyone for inviting me and for being here. I'm afraid that I have to start with a technical issue because I cannot share my slides from here.
Okay.
I could do it without the slides. I try to.
Non ce li ho qui. Ok. Può controllare. Just a minute. We will check.
Devo mandare le slide lei?
Sì.
Ok,
però non riesce a proiettare. Deve farlo diventare esatto. Ok.
Non riesce a condividere lo schermo.
Imposta come?
No, che condividere lei.
Ok.
Shall I do it without slides?
Button, ok, or cosa possiamo fare? Se no le metto su io, ma le devo
No, le deve
io.
condividere lei, deve fare share.
Can you
qua.
share the screen?
When I go to share screen.
What do you see? Okay.
Okay.
Okay, it works.
Okay, thank you.
Okay. Can you zoom out, please? Okay. Okay, it works. It worked perfectly. Thank you, Barbara.
Thank you very much. So sorry about the glitch. As Linda was saying, I will talk about personalized medicine today. And also cover this notion of precision. Precision medicine is one topic that is increasingly in the focus of attention of social scientists as well. So what do we mean by personalized medicine? I think here we need to distinguish between whether we talk about the concept of personalization or the practice of personalization. many clinicians and many could you mute your microphone? Sorry, I have a lot of noise in the line.
Yeah, we can hear you.
No, can you mute your microphone maybe? Thank you. Super, thank you. So many clinicians remind us that personalization is not a new phenomenon. It's not something that was invented in the 21st century, or not even during the Human Genome Project. The book that you see here, this is a book cover, a photo from a book from John Berger in the 1960s. He wrote a book about an English country doctor. And the country doctor, he practiced personalized medicine in many ways, because even if we use the definition of personalization that the European Commission uses, namely the consideration of individual characteristics at diagnosis, treatment, and prevention, then this is what he was doing. But of course, it's a very different way of using evidence, a very different type of evidence, and a very different way of personalization than the one that you see on the slide in the middle. This is Adam Hedgecoe's famous book about the politics of personalized medicine. This was the beginning of the concept of personalized medicine after the Human Genome Project, when the matching of group characteristics, genetic characteristics to drugs were the lowest hanging fruit. So the Human Genome Project had required a lot of public and private funding. There was a lot of hope around it, and it didn't really deliver much in the early days. And then pharmacogenetics, or personalized medicine, as a synonym for matching drug treatments to genetic group characteristics, became the poster child of personalization. Personalization as a concept was also embraced by researchers, because before that, what they were doing was called race-based medicine, when they used ethnic labels and racial labels as proxies for markers that corresponded with drug metabolism. So the label personalization came from a very different direction in those days than the old personalization, the kind of country doctor personalization. And also because, well, I should say that personalization then became the subject of much critique, because it wasn't individual, because it raised expectations that it couldn't keep. So in a deliberate move away from the label of personalization, the National Academy of Sciences in the United States chose the word precision to describe what they understood as the latest iteration of personalization. So the Obama administration inaugurated what was called Precision Medicine Program in 2016. It is now called All of Us Program. So it's a pun. The US, of course, is also the acronym US. But the latest iteration of personalization in the form of precision is different from the use of genomic information. So the famous slide from the National Academy of Sciences report in 2011, that was the blueprint for the Obama administration's precision medicine program, really had this idea that human health should work like a Google map. That's literally how they called it. So it should be an integrated map that combines stable information, relatively stable information, such as, well, the genome sequence in this case, so the sequence of nucleotides, and then more dynamic information, such as the microbiome, the epigenome, also behavioral and social data increasingly. And if you got all of this together, then this is what was the argument was, we would be able to overcome some of the shortfalls of previous, what they called blockbuster medicine. So blockbuster medicine is the medicine that we are used to today. When people are healthy, they stay at home. When they're sick, they go to the doctor. This was in non-COVID times, of course, but when they're sick, they go to the doctor, and then the doctor captures the data and checks what's wrong. And precision medicine proponents say that that's not a good way to do it. We need to collect data throughout people's life course, across different organ-specific knowledge and domains. So essentially, this latest iteration of personalization in the form of precision medicine makes 3 promises. First, to move to more systemic and multi-omic approaches, so not just genomics, or not only the narrative evidence and the physical evidence that the old country doctor had, but all of it together. The second promise, and we're really in the sociology of expectations here, because this is not reality for most of us. For almost everyone on this planet, this is not reality of the clinical medicine that we're getting. The second promise was closing the actionability gap between evidence-based medicine and individual patients. This is what the slide on the right means. This is a slide by Nick Shork. He called it imprecision medicine. So we know that the drug works in 1 out of 5 patients, for example, but we do not know whether it will work in me or in you. So how do we close that gap? And then the third promise is that medicine would move from symptomatic and episodic medicine. This is the snapshot medicine that I mentioned, from a kind of continuous to pre-symptomatic medicine. It's a very interesting shift. The idea would really be that people would be monitored across their whole lives at times of disease and at times of health. And then, in a way, every patient would become their own control group. So the idea was, and this is why there's the Apple Watch on the slide here, the idea would be that the algorithms know whether someone will experience a health problem before they know. That's really the idea of proactive medicine. And, you know, some of those promises, I think, are promising in the sense that this approach of precision is making some new connections, bridging some gaps that older versions or that current and previous practices of biomedicine did not make. So one of them, these are just examples, is that indeed precision medicine is trying to bridge organ and disease-specific expertise. So we had, first of all, we have a lot of systems approaches now. We had, as some of you will know, we now have drugs approved that are not organ-specific anymore, so-called site-agnostic drugs in oncology, but they have approved for particular molecular characteristics of tumors. So we're really moving away from these silos of here's the expert for mouth and nose, the expert for everything orthopedic and so on. Even oncology is merging with immunology and so on in certain areas. So there are lots of cross connections here. Also, closer connections between individuals and populations. So precision medicine is not an individualistic medicine in the sense that you look only at one patient, you look at the patient in great depth, and then you draw conclusions from that. That's part of it, but you continuously move between the one patient and the population. So there's a constant oscillation between patients and the individual patient and the patient population. In a much faster way than it used to be the case in older laboratory medicine, where we also had this oscillation. Laboratory medicine always created generalizable information or aimed to do that, used reference populations, normal ranges, but this is much faster and much more multifaceted. Then there is at least the aspiration, the hope that we have a stronger integration of biophysical and social and personal factors, not always in the way that data protection and ethics experts would want it, because as you can see here on this slide, it's from 2014 from bioinformatics experts. They said we really need to bring all information that we have about people together in order to personalize their healthcare. And of course, you will not read everything on this slide, but it includes social media postings, credit card purchases, police records, because the key idea is the data mining notion that even if you don't know the functional pathway that underlies a correlation, if you don't understand causation, the correlation is already actionable. So what do I mean by that, especially in terms of prevention? If it turned out that somebody who tweets in the middle of the night, as one famous American president, for example, has a greater risk to suffer mental health problems, then you can focus on these groups in terms of prevention. But you can also, of course, if you're an insurance provider, you can say, I'm not going to insure those people. So this was, of course, a simplified example, but the idea is that you don't need causation in order to act in some cases. And the causation here could be that people who tweet at night already have health problems, they can't sleep, or the fact that they are up in the middle of the night creates health problems, but the causation isn't even so important. That's the underlying idea. And this is what some people literally say. They say causation is no longer as important in medical research as it used to be. So I won't say much about value-based healthcare here, because this would be too much for the time allocated to me. But just one thing to say, that there is also a greater integration of biophysical and social personal factors around the use of patient-reported outcome measures, patient-reported experience measures. So in a nutshell, a greater shift towards using for decision-making and also for reimbursement things that give value to a patient. Not merely in terms of patient satisfaction, but in terms of functional changes for the patient that might not be clinical parameters in the strict sense of the word. So now, after this positive assessment, really, a slightly less sanguine take on the challenges that we're facing. First of all, the common currency of all of this is the data point. All of the developments, all of the trends that I've now, or all of the promises that I have explained, they revolve around data. So without data, without the patient being willing to share her data, precision medicine doesn't work. This is why I called my book Empowered Patients ? Because it's true that patients have a much more active role, but this is not only empowering. Precision medicine also requires that patients agree to having their data looked at, analyzed, and to sharing the data in the first place. So this is the key difference to the old personalization of the country doctor who knew a lot of the individual characteristics of his patients by knowing them, by knowing their social environment. When the doctor died, the knowledge died. In terms of data, when data is the common currency, it gets depersonalized. So for the sociologists of medicine, this is of course very much what Nicholas Jusen talked about when he spoke of the disappearance of the sick man, quote unquote. So Jewson said medical cosmologies have changed in laboratory medicine because in the very old medical practices, patients spoke for themselves. They would describe their symptoms. They would say, this is where it hurts, this is how I feel. Laboratory medicine replaced instruments, replaced patients by instruments. So the instrument spoke for the patient. This is what Jewson meant by the disappearance of the sick man. And some people argue that with precision medicine, the patient comes back into the equation. But I would argue that it's not really the patient that speaks for herself, but the data speak for the patient. And this is also what Henrik Vogt and colleagues have pointed out when they said, yes, precision medicine is holistic. It's true, but not in the kind of humanitarian holism way that some of us have in mind when we hear holism. But it's a very techno-scientific holism. This is how they call it, where each person's life process is defined in biomedical and in techno-scientific terms. It's quantifiable, it's controllable, and it's underpinned by a regime of medical control that comes from everywhere. That's the vision. So this is a far less sanguine vision than the vision that the proponents of precision medicine promote. So that this is a sort of side note to emphasize that this vision also has some, I mean, I'm at the Department of Political Science, I'm a policy scholar, so this has policy relevance as well. This is the former Health Ministry, General Secretary of Health, Jeremy Hunt, in the Health Ministry in the United Kingdom, who said in 2015, well, this was at the time when the United Kingdom was treating their junior doctors very badly. They changed their contracts. And the work conditions for junior doctors really deteriorated. Nobody understood why, because everyone agrees doctors are important, right? Now during COVID more than before, but even then. But he said, no, we don't need to be so nice to the junior doctors. And here he actually said why, because he said, if medicine is becoming more datafied, digital, then we need fewer human doctors and more machine doctors. So we don't need to treat the humans so well anymore because computers will replace them. So this is, of course, bringing us right into the politics of data in healthcare. And there are lots and lots of challenges that emerge in this context that sociologists have only begun to look at in the context of precision and personalized medicine. Many of the issues are issues that we're facing in all domains of datafied digital practice. Some of them are quite health specific. So some of them that we are facing everywhere are that we have new ways of producing data about everything that people are doing, almost everything. New ways of linking data. We have the end of structural privacy, as Harry Surden called it, so that because so much of our bodies and lives is now recorded on data, our privacy decreases just because of that, by structural factors. But in the health domain specifically, we also have a lot of new power asymmetries and new commercial actors. So among the main powerful actors are not necessarily pharmaceutical, they are not only pharmaceutical companies. They now receive a lot of attention again because of the vaccination debates. But I would argue that at least as important as pharmaceutical companies are tech companies. And tech companies matter in the space of precision medicine and medicine more widely in 4 different ways. They produce the tools with which we collect data, the software and the data. They decide where medical funding goes, because some of the tech entrepreneurs have big philanthropies where university researchers are now applying to the Mark Zuckerbergs of the world and the philanthropies for funding for medical research, including basic research. And this is what you see here on the slide. There are some companies, tech companies, that are clearly moving into the health domain. Amazon is an example. This used to be a company comprising of Amazon, JP Morgan, and Berkshire Hathaway that wanted to revolutionize healthcare because they have so many people, so many employees, that they said, we will provide a new healthcare system. We will invent a new healthcare system and provide healthcare to all of our employees, millions of employees. This has now folded, but nevertheless, Amazon is still in the health domain, and it's very much in the background. They don't want to be visible too much, but tech companies really create massive power asymmetries here, and exacerbate them. Another thing that we're seeing is, this is a classic article by David Armstrong from the 1990s, where he talked about surveillance medicine. For those of you who know this article, you will remember that he said surveillance medicine really means that the population and the whole population moves into the center of attention, and also aspects of life that were not health related or not medical related, they're now also moving into the focus of surveillance. And this we have at a massive scale in precision medicine. This idea of continuous health, that we need to monitor people continuously in order to understand how the bodies perform at the time of health and not only at the time of illness. The idea that your personal devices should find out whether you get sick before you do. And also this notion of disease interception that companies such as Johnson & Johnson are promoting now. This is actually a term coming from military language, you know. It's like a bomb interception. So the disease is already there, and we need to intercept it before people realize it. The idea is that people will use diagnostic instruments and also drugs much earlier. So, and here I'm coming to my main and final point, to the new divisions. We have some old divisions. This is what the first slide here shows. Some people said, well, precision medicine, so data-driven, it means that we don't suffer from the old problems anymore that we had in clinical trials, that women were missing and kids were missing. Now we can include everyone. Well, no, it's just that we find it harder now to see who we are missing. Because even if you include everyone, the whole population of a certain hospital in a large personalized imaging study, then you're excluding those that don't have access to healthcare. So the problems are not solved, but they are moving and becoming more difficult to discern. This is what Ine van Hooijwegen and I have called silent rationing. So it's not a rationing where we say, you are 70 years old, you won't get a new hip, or you are 90 years old, you won't get a new hip. But the idea that we use neutral evidence to make decision, for example, on prognostic success. If we just say the neutral evidence tells us that people with these and these and these characteristics have a greater chance to recover well, so we will give the scarce resource of a particular intervention to those people. What happens then is that even if we use this neutral evidence, the neutral evidence sometimes has social and economic disadvantage baked into it. An example from the COVID pandemic, this is not a personalized medicine example, but it illustrates the dynamic. If we say that we use prognostic success as an indicator for who gets a respirator, then we are disadvantaging socioeconomic disadvantaged people even more, because health status and overall health is an important predictor of prognostic success, and poor people have much lower health, a worse health status on average. So those that were already disadvantaged will then be disadvantaged further. To give you another example, if we say it turns out that people who live in these and these and these neighborhoods with this and this air quality have better prognostic success because their respiratory system is stronger, then this has clearly to do with air pollution. And who lives in polluted areas? It's more the disadvantaged people. So the type of discrimination is not new. What is new is that it tends to get hidden under the covers of neutral evidence and data mining. So I'm getting to the end. I will now skip the interpretation gap because I don't have much time for that. I want to make my final point about precision medicine and how I see the vision of the future of it, and how I see the role also of sociologists and social scientists and ethicists. So if precision medicine remains so focused on data as it is, then I think the development is that there will be automated medicine that uses algorithms to diagnose problems. We already have it in the United Kingdom, where you can't get to a doctor anymore before you get through symptom trackers and people on the phone who use an algorithm to determine whether you really need medical attention. So this kind of automated medicine will be the medicine for the masses unless we have something acute or very serious. The personalized precision medicine, where you have lots of tests done and you have human beings who sit with you, who interpret the data, this will be for the 1%. The boutique medicine will be limited to people who can afford the human minds, the human interpretation. That is actually the expensive thing about precision medicine. The production of data is not the expensive thing. The expensive thing is the interpretation. So the conclusions are, and these are normative conclusions. These are not analytic conclusions only. So I stand by that. I think it's very important also as sociologists to derive normative conclusions here on the basis of our analysis. It's very important that we make the categories and practices of stratification visible and accountable. So if precision medicine says, great, we can now, in the olden days, we would just say there are 3 types of people: kids, adults, okay, and very old people, but then maybe also women and men. But these are the categories that we use. Now precision medicine uses a lot of categories, millions of them. It's a dynamic, automated process of stratification. We use molecular characteristics in combination with other characteristics to decide what disease you have, what treatment you get. That's fine, but we need to make the categories and practices visible and open and transparent. Otherwise, we get into silent rationing. The second point, some people now say, okay, precision medicine undermines solidaristic healthcare. Because if we know so much about individual difference and the costs that people create, this undermines the basis of solidarity. I don't think it has to, because solidaristic healthcare already knew that it was ignoring difference in terms of risk. So when solidaristic healthcare systems were set up, people knew exactly that some people would cause more costs than others. Think of the time after World War II, where it was well known that people who were injured, who had suffered severe trauma, would be much more expensive than others. Children born with disabilities are more expensive than others. But public healthcare systems decided to deliberately ignore those differences to create a system where everyone pays what they can and everyone gets what they need. So there's no reason why we should not do this now. So we should refrain. We should, of course, use this information, but we should refrain from using this data and information to determine contributions that people make to the system. So let's not translate the greater knowledge we have about people to into some kind of idea about how much people should contribute. And the final point is that it is very, very important that people's fundamental needs do not need to be met on the free market. 2/3 of the factors that account for people's health outcomes are not in the healthcare system. So precision medicine now goes further and further out of the clinic, looks at more and more aspects of people's personal lives. It is a key thing for well-being, and we are undoing some of the powers of precision medicine if we do away with welfare states, with public infrastructures, with those things that people, with those needs that people get satisfied by good public services. This is not a very sexy message. It's not very high tech, but this is more important than ever. And we've also seen this in the pandemic. Okay, I stop here. Thank you so much for listening to me.
Thank you, Barbara. Thank you so much for your eye-opening speech. I'm sure that there will be many questions from the audience. I have questions too, but I want to give space to our participants before. Please.
Thank you so much for your lecture and for all your work that is so clear and at the same time so interesting, as it raises key issues for the present, the future of medicine, and for the present, the future of the sociology of health and illness. I would like to ask you many questions, but I'll limit myself to a couple. So the first one is quite a broad question. Don't you think that PNP, so precision and personalized medicine, has somehow failed to meet the expectations and the promises in the face of the pandemic? Because we saw that all the fixed labels have been used, for example, in a vaccination campaign. And also we saw that what you call big interpretation lacked, at least at the very beginning of the pandemic, when we already had big data to interpret it. The second question is more specific, because you said that you disagree that PNP medicine would inevitably lead or foster an individualized, a more individualized medicine and view, arguing that it connects the individual level with the population level. But my question is, can this connection be enough to build new collective identities? Because I'm not sure that the fact of sharing molecular or multi-omic citizenship could really be enough. And what can substitute that shared labels that were used to identify patients suffering from an alleged common disease, and that underpin the construction of collective identities and of patient movements, for example. Just to make an example, we could have the association of women with the mutation of the BRCA1 gene, but this would mean adding a segmentation, a further level of differentiation. And what about the commonalities? That for me is the sharing of the same illness experience. Or to make just another example, this multi-omic approach together with behavioral and social data has been used to try in the field of biological aging to try to identify more fluid categories instead of chronological age. But still, again, what about the common factor of experiences becoming old? Thank you.
I'm sorry, the common factors of experiences, just the last word I didn't hear.
The second example?
The common factor of experiences?
Of becoming old.
Ah, okay. Thank you so much. Well, thank you so much. Some of those questions spoke from my heart. But I start with the first one, which I hadn't thought, which I had never thought about actually in these terms. I wouldn't say that anything having to do with the pandemic is a failure of precision medicine in a sort of narrow sense of the word. But I think it's a brilliant analysis of yours to conclude that many of the ingredients of precision medicine, they have actually failed. And that should make us wonder what we should think about, or how promising, how strong this whole promise of precision is. So what I think we can learn from the pandemic is that the aspirational content of precision, however we might see it, really depends on a lot of bread and butter questions that people sometimes don't consider. So interoperability of data. In Austria, we are not able to match data from the city of Vienna with vaccination data. It's not possible. So it has had huge cost in people not getting vaccinated because we don't actually know who the unvaccinated are. So this is an argument that I've once made with Hannah Kienzler, my colleague at King's College, from when I was still there, that the rich world is often prides itself that everything is so great, and the poor world can learn from us. This is really something when we can learn from others how to do data integration. So many of those things have not worked. What hasn't worked is that we can really look after the most vulnerable, also socioeconomically. So I think that it's a very, very good point that many of the things that precision medicine relies on have proven to be problematic during the pandemic. The main lesson from the pandemic, I think, is the same for the pandemic, for pandemic preparedness, as it is for precision medicine. And this is the point I ended with. The basic questions, the fundamental questions about not only equity and access to healthcare, but also access to housing, access to education. These are so important. And we could have learned this from the last pandemics, and we haven't. And so we're ignoring this in pandemic preparedness, and we're ignoring it in precision medicine. So very briefly about the second question, I think here the answer is easy. I think those connections that I drew out are not enough to create new identities. The only aspect where I see some hope that there could be some collective action based on shared identities is datafication. This is something that Ine van Hooijwegen and I have talked about and also written about, that if you remember this large activism around the use of genetic data by insurance companies in the 1990s, we need something around data more broadly now. So, because some of the same risks that the use of genetic information posed for people in terms of making them, disclosing information about them, making their health predictable to some extent in insurance terms, we have this now with broader types of data. There's no reason to limit this argument to genetic data alone. It's an argument that should apply to all data. And we see relatively little collective action around that now, but I think we could in the future. And I think COVID will also fuel this process in some way.
Thank you, Barbara. Other questions? Okay, Monica, Dr. Presepino. Okay, sorry. Try to be short.
Yes,
Monica.
I'm fine. Okay, hi, Barbara. My name is Monica Morero.
I can't hear anything. Sorry.
Mike?
Sì, vai.
Okay, can you hear me now?
Working again. Thank you.
Hi, my name is Monica Morera. I work for the University Federico II, and I'm working on artificial intelligence challenges. So I try to be a little bit provocative, if you don't mind, while saying, of course, I enjoy your presentation, and ask to yourself and also to my colleague here that I've enjoyed the presentation, why we had this failure then? What was the impediment? Since we have data, we have the big data, we have, well, some of them, but also at the international level, what was the problem with that? Why we couldn't really implement the use of AI in formulating COVID reliable answer? Okay, so this is my question to you, and I will try to reply a little bit. The problem is because we didn't have reliable data in the making, in the infrastructure. Imagine, I said before, I work for the World Health Organization. We have people that send us fax. So we have all the infrastructure for data. We will talk about that tomorrow morning in the Eroica section, also with my partner in that. So the problem of that, I don't see at all, this is my provocation to you, Barbara. I don't really think we are, that the future is the digital doctor. I totally disagree with that. Because artificial intelligence, a really great way of arriving to the people, to the low-income people, to the poor people, the people who are sick with comorbidity, is an assistive technology to doctor. I don't really see the digital doctor, but I believe in assisted. I don't think this gadget like Apple, yeah, I can do an ECG now as we speak. But it's not the point. I already have artificial intelligence that can read my face and tell me if I might be a person who will have heart attack in 10 years. We already have this kind of technology, which is great. And I want this to arrive to the poor people. I want to arrive to people that have no idea that these things happen in a very effective, low-cost forms. So this is my fight in terms of really making democratization of health and using artificial intelligence for the humans and also for the pets, because I don't mind. For animals, there's also already things for cats and cows in the business of cow things. But so I think and I conclude, and I ask your opinion, Barbara. I mean, artificial intelligence in the last 5 years that made huge differences. And I will challenge you on this, on the literature that you presented, because we really did so much in 5 years. And I can't imagine what we will do in 5 years, but we are very in the failures. That I conclude. So I'd like to think who us as scientists can help policymakers be also as a sociology here our involvement in this. Thank you.
Do I still have time to answer?
Just a second, Barbara, and we will collect the question before, please. How much time do you have?
5 minutes.
Okay, very short.
Yeah. Hello. Mi vede però.
No, pazienza.
Okay. I am Christian Pristipino. I am a cardiologist, and I work with systems and precision medicine research since some years. My question also, it's more than a question, it's kind of knowing what's your opinion on this perspective, which is that in fact precision medicine has a very high risk of falling into a reductionist approach, a complicated reductionist approach. if we perform this kind of precision medicine, we will never get the real shift and progress that we are expecting from it. On the other way around, if we try to focus on the emergence of properties of interacting networks, this is the way we should go with this kind of approaches. And this opens also very new landscape to sociology approaches, because sociology becomes an emergent property of interacting networks of individuals. And that may have fallbacks to the individual and to society itself. So I would like to know, how do you perceive the future as regulators grasping this aspect?
Very telegraphic.
Yes.
I'll be really short. So I'm Julia Rakcheva from the Italian National Institute of Health at Sapienza Rome University. And I just wanted to ask two questions very briefly. First, do you think that the key words to respond to the challenges of robotic and algorithmic medicine would be a choice, so to give just patient a choice to choose between artificial or human doctor? And the second question, if you don't mind, could you please give a comment from the sociological point of view of the recent measures took by the Austrian government for non-vaccinated lockdown? Thank you.
Thank you. Thank you. Thank you. Please, Barbara.
Thank you, and I'm sorry that I'm now rushed, but I have to lead a department meeting. This is why. So I will highlight, I will zoom in on two aspects, and for the rest, I'm very thankful for your comments and observations, which are food for thought for me. I will first say something about artificial intelligence and the scenario of automated medicine. I think, well, I hope you're right. I really hope you're right. However, I think I'm less optimistic than you are that people will make a difference between what works and what's cheap and thus palatable. So I would fully agree that automated medicine and the use of digital tools will not provide good healthcare for everyone. I fully agree with that. Do I think that the temptation to use it will still be there for a lot of non-serious diseases, to sort of screen people for whether they have a serious concern? I know that people are proposing this, and I fear that there will be pressure because if something works for many people, then the outliers will be ignored. That's my fear, although I hope that you're right, and I fully agree with your hesitance about saying that, AI will revolutionize healthcare. Here, I totally agree with you. I just feel that among policymakers, and I observe it, that we are moving to algorithmic decisions where we shouldn't actually already now.